ascites, in that cases, I will evaluate the patients whether I will go for, can we go for the upfront surgery. And for doing upfront surgery, I will go for the laparoscopic evaluation for the patients. If laparoscopic evaluation also, it give me the conclusion that I can go for the primary debulking surgery and complete cytoreduction that is less than 1 centimeter, disease can be optimally debulked, and in that case, I will go for the primary debulking surgery. Otherwise, the patient will go for the interval debulking surgery.
Thank you, Professor Shahana, ma'am. So here in the stage 3C means there is ascites with multiple nodules in the peritoneum. Even in this case, you are favoring upfront surgery, or you will prefer neoadjuvant chemotherapy. That is my question. So stage 3C, ascites there, peritoneal metastasis. You may consider that this our performance status is stage 1, ECOG 1 or 2. So even in then, are you in favor of upfront primary surgery or neoadjuvant chemotherapy?
If ascites is more in that cases, there was, as we have seen that in advanced stage disease, that is in stage 3C and stage 4, in that cases, the PORAS trial and the URTC trial, they have shown and they concluded that in both the trial, they concluded in both cases in upfront surgery and also in interval debulking surgery, there is no difference in progression-free survival and overall survival. But only difference is that if it is the neoadjuvant chemotherapy, we give the neoadjuvant chemotherapy. In that cases, it increase the resectability, it increase the resection rate of the disease, and it increase the decrease the duration of surgery. It decrease the blood transfusion and decrease the bowel resection. And in that cases, we may go for the interval debulking surgery.
Thank you, Professor Shahana, ma'am. So we have treated this patient with 3 cycles neoadjuvant chemotherapy with pacli and carboplatin, followed by interval debulking surgery. And after that, we completed 3 cycles chemotherapy with the same schedule, pacli and carbo. Now, my question to Professor Ferdous bhai, are you here?
Yes, Sumon. Yes, Sumon.
Okay. My question to Professor Ferdous Shahriar side, sir. So, in this context, after 3 cycles neoadjuvant surgery complete, patient presented, patient completed for the 3 cycles chemotherapy. So, what else you want to do in these patients in sitting in 2021?
Basically, I would go for this BRCA study, whether done or not.
No. Till date, no BRCA mutation is done.
Okay, so if possible, I'll go for BRCA study and at least genetic mutation study, and if still possible, go for if the genetic study is negative, then I go for this somatic study, and then find out that whether they are BRCA1 or BRCA2 positive. If they are positive, in that case, I would go for this maintenance Parp therapy with olaparib. That is the option that is open to us now. And if I cannot go for BRCA mutation study, niraparib is a drug that can be used, but that's not available in our country.
So okay, I'll come to you later.
Right.
That we'll discuss later. The question is whether you are going for any further investigation or not. Whether you are going to BRCA status.
I would go for BRCA status.
Okay, Dr. F M Kamal Uddin, sir, do you have any opinion regarding these issues?
So, Sumon, as per standard guideline, I'm talking now about country. The BRCA mutation is to be done the moment the patient is diagnosed with ovarian cancer. We should not wait till the patient complete all these things. So, the total recommendation is that we should do a BRCA mutation of any diagnosed ovarian cancer. And then we can use it for many other things like prognosis and other things. Yes, I agree with those that if it is positive or either HRD or genetic mutation, we can go for Parp inhibitor maintenance.
So you are in favor of doing this genetic mutation test. So Professor Parvin, Akhter, Banu, madam, what's your opinion?
Thank you, Dr. Sumon. Hello.
Hello, madam.
Can you hear?
Yes, yes, ma'am. Clear and loud.
Yes, I agree with Dr. Shahriar and Dr. Kamal Uddin that from the very beginning, BRCA mutation and if possible, all the genetic mutation HRD, of everything should be done. And then to decide about the maintenance therapy with olaparib. Yeah,
Thank you,
because
madam.
this patient is a high risk and high grade serous carcinoma. So this is the best option.
Thank you, madam. Professor Mofazzel Karim, sir. Can you hear me, sir?
Yes, I can
Mofazzel
hear you.
Hossain.
Okay, sir. So what's your experience, sir?
He always says Mofazzel Karim. I am not Karim.
Mofazzel Hossain, sir.
I'm
Sorry, sir.
Hossain.
Sorry. Sorry. So Mofazzel Hossain, sir. So what's your practice regarding this case, sir? Are you routinely use this BRCA test at the very beginning, or you have different options, sir?
Well, the patients usually come to us, most of the patients, even if it is stage 3C, I find that the patient is coming with coming after surgery. But if the patient comes to me, what you did, I do the exactly same thing. I administer chemotherapy because that gives a better access to the surgeon for doing the surgery, and that reduces the bulk and also gives an indication about the chemosensitivity of that disease. Most of the patients does well. Most of the patients go into almost remission before the surgery is contemplated. So you did 3 cycles of chemotherapy, that was excellent, and she responded, then went to surgery. First time doing BRCA test, yes, as per current recommendation, everyone should practice that. I try to do that, but the cost is always there, involvement. But nowadays it has come down to, I think it is around 35,000 or something like that. So I'm advising it to my patients for the test, and if it is positive, then well and good. But if I cannot do that, or the patient is not interested, I try to convince them. If the patient are in agreement with me, then I can I carry out the test, and I also counsel them about their offspring, their siblings. I talk at large with them, and then after completion of the surgery and chemotherapy, in advanced case, in this particular case, you could add even bevacizumab upfront with chemotherapy.
Sir, we will come later with this topic, sir. So
Okay,
now our
okay,
discussion
but-
is whether we. So
Right.
we are agreed that all the panelists are agreed that in ovarian cancer we should do the
We should
BRCA
carry
test.
out BRCA1, BRCA2 test.
Okay.
Right. There is
So
no doubt about it.
now the question, sir, what should be the timing? So at the time of the very diagnosis, or you will do a later? Let's see what 2020 is saying. That testing for germline mutation is recommended at the time of disease diagnosis as soon as possible. So whenever a patient came to you, you should do the BRCA mutation test, irrespective of stage, irrespective of anything. So for the participants of those here, there are two mutations over here. One is germline mutations. For germline mutations, you have to test the blood sample, and the somatic mutations, you need to do the tissue samples, that is the cancer tissue cells. So when to do what? So at first we need to do the germline mutations. If we get germline mutations over there, we need not to do the somatic mutations. But if there is no germline mutations, that is the blood test comes negative, you need to do the somatic test for BRCA1, BRCA2. So besides this BRCA and BRCA2, in our upcoming discussion, we will use another terminology, that is the HRD, that is the homologous recombination deficiency. That is another type of mutations, but it is not a specific type of mutations. This is a one kind of score, we could say, that all type of homologous recombination deficiency mutations, they could do a score, and according to this score, they call this HRD deficiency or not. So we should do BRCA test, germline mutations. If it comes negative, we should go for somatic mutation as well as BRCA test with HRD mutation status. So if the patient comes with BRCA negative, you might get HRD deficiency. So that is the point we should need. We need to test at first from blood, BRCA mutations, germline mutations. If it comes negative, we should test that, send the sample for somatic documentation as well as the HRD score. So our patients 3 cycles neoadjuvant chemotherapy, complete response, BRCA status positive. Now my question again to Dr. Ferdous Shahriar side, sir. So BRCA is positive. So what's your opinion regarding further treatment? Dr. Ferdous bhai, can you hear me?
Sumon, right.
Yes.
So whether HRD test is done along with BRCA or just
No,
BRCA test?
BRCA test is positive. That's why we didn't proceed
Didn't
with
go for
this is germline
okay.
mutations.
Okay, so I'll go for olaparib for this patient, and maximum for 2 years. And if patient is disease relapse free, recommendation is I as far as I know that recommendation is 2 years. So I'll go for 2 years.
So you are in favor of first line maintenance with olaparib, right?
Right.
As it is recommendation. Okay. Right. So what's your opinion, Dr. F M Kamal Uddin, sir?
So Sumon, I will discuss with the patient and I will explain that this type of patient, the patient recur within first 2 years time. So there is a chance of recurrence, and we have something to do, because before offering the patient, I need to explain him the pros and cons. So we can tell her that if we give her olaparib, that is Parp, and as a maintenance for 2 years, the chance of it will cause 70% reduction of the recurrence rate. So that is a huge thing. And if you look at the PFS, the PFS benefits is much higher than doing nothing. If I give nothing and if I give olaparib, so there is almost 3%, 3 times more. That is 60% versus 20%. So this is almost 3%, 3 times more progression-free survival benefit that we can get from olaparib. So explaining all these things, but again, we need to understand it is very expensive drug, and there is still no data that if she continue for 2-3 months or 6 months, then discontinue, what will happen? We don't know, which is the reality in our picture. We need to convince that they need to have some drug and which Dr. Ferdous was telling, and there is an expected benefit like this. And if she agrees, then we can go for it.
So thank you, Dr. F M Kamal Uddin, sir. This is the number one topics that we really want to highlight, because we are talking about the practice changing aspects. So right now we are not in favor of, and I don't know whether you are practicing or not, we are not in very practicing with maintenance therapy. So we are talking about practice changing concept. So Dr. P. Banu madam, what's your opinion? Would you really like to maintenance with olaparib, or you opted for wait and let's see what happens?
No, thank you. Yes, I am in favor of maintenance olaparib, as clinical trial like Solo 1 and Prima clinical trial showed that there is a very good progression-free survival rate with maintenance olaparib, more than 60% versus 25% in placebo. And even at the end of 5 years, also very good progression-free survival, about 48% versus 20%. So we should talk with the patient if they can afford the drug, because it is, as Dr. Kamal mentioned, not for few months. It should be given at least 2 years. So if the patient can afford, then we should keep olaparib.
Thank you, madam. Professor Mofazzel, sir, what's your opinion regarding maintenance olaparib at the very first line?
Well, if we consider about the olaparib, I will explain to the patient that the maintenance will give you a later recurrence, not earlier than if you don't give. So this has to be explained to the patient. If the patient can afford, then only I will give it, because in all patient I will not give it. But if the patient can afford, we should give it, because there is definite PFS benefit, though there is no OS, overall survival benefit.
So, so there is a very good consensus among our panel of experts that if the patient is BRCA positive, even after completion of first-line chemotherapy, if the patient is complete response or partial response, then we should consider about this olaparib if BRCA status positive. So let's see what's the design. Already Parvin, Banu madam already mentioned this study. This solo study, yes, this solo study you could see that after completion of chemotherapy, if complete response or partial response is there, they have trials with olaparib versus placebo. And 5 years progression-free survival rate, you could see that there is a huge difference in progression-free survival. So yet not, we didn't receive the overall survival, but you could see that the progression-free survival, we hope that this will reflect in the overall survival. So we are very much agreed, and it reflects with the panel of experts that in first line, if the patient is BRCA positive, we can consider this olaparib therapy. Now the question is come that Madam, Banu Madam, you could see that the BRCA mutation status in ovarian malignancy might be 15%, 15 or 20%. So there is a huge percentage of patients that are devoid of this mutation status. So whether these groups are really devoid of getting this benefit from this PARP inhibitor, can we avoid mutation test? Is there any group whom you can really offer this PARP inhibitor without BRCA mutation status? Parvin, Akhter, Madam.
Yes, thank you. Yeah, there are some clinical trial like Paulo 1. They enrolled all patients, HRD, BRCA, positive, negative, all patients. And of course, BRCA mutated patients and HRD positive patients showed much more benefit. And the median progression-free survival was almost 37 months versus 17 months. But yes, there are incidents of giving without mutation test.
Thank you, Madam. Professor Mofazzel, sir, what's your opinion?
Yes, I think we can avoid in some patients because there are studies which say the drug, this veliparib, can be given even without knowing the status, and they are prescribing it. And the study that Dr. Parvin Akhter Banu referred, they also put this in both BRCA1 and BRCA negative group, and the benefit was less in the negative group than the compared to the those who are positive. So that's what I have to say.
Thank you. Dr. Ferdous, Shahriar side. So are you favoring giving this PARP inhibitor without mutation test?
Yes. In one of my patients, I have done this exactly this thing. I could not go for this BRCA test. At that time, it was not basically reachable, or it was not available. So what I did, the patient was not whatever the reason, I could not go for BRCA status. But even though I gave the patient olaparib, and it was a high risk patient, and fortunately that patient was fine up till 11 months. That is fortunately or unfortunately, whatever. But after 11 months, she had tumor progression. So I'm not sure whether it was a good idea for me to offer her this olaparib without doing the BRC status, because ideally the patient should have been better for two years, at least. But that patient was okay for 11 years. Then she had progressed on the progressive disease. So that's my personal experience.
So thank you, Ferdous bhai, for sharing your personal experience. But let me share including all the tests, Solo 1 and Solo 2, all the tests, they tried olaparib only even the BRCA mutation status. If you really want to avoid this mutation status test, then niraparib or velaparib might be an option.
Yes.
But olaparib, I think there's probably no evidence that suggests that giving olaparib without BRCA mutation status. Let's see what Dr. F M Kamal Uddin says. Dr. F M Kamal Uddin, sir.
So, what Ferdous said, yes, sometimes we are lucky because not knowing the status doesn't mean it was negative. So maybe it was positive, maybe it was HRD, so we don't know. But as you said, I totally agree. There is no data of giving olaparib in BRCA wild type. But in case of niraparib, yes, there is a scope to give. But if you look at the outcome of Solo 1 and the study of niraparib, that is the prima, then you will see the overall niraparib has done good in all the patients, like both mutant and non-mutant. Again, the subgroup analysis, mutant has done better than the non-mutant. But if you look at the overall response of olaparib is much more better than niraparib. So personally, I mean, if you look at the head-to-head group 2, olaparib is the better result, number one. Number two, yes, we can go for niraparib, but the problem is it is for 3 years. And again, the benefit is very marginal. It's not like olaparib. So explaining all these things, if somebody is negative, we cannot avoid it. If somebody is negative, we may discuss the possibility of niraparib, which is not available probably in our country, that there is some options, but I think there is no scope to avoid it. I mean, you cannot just avoid because you have a better option in hand, that is olaparib, which is giving you a huge benefit. So we should do the test, and if it is negative, then we can discuss about the niraparib.
Thank you, Dr. F M Kamal Uddin. So let's see what the trial says. That the prima trial, unlike Solo, they have enrolled all the patients without the BRCA mutation status, and they have tried with niraparib. Let me mention, these are all in first-line test after surgery, after completion of first-line chemotherapy. They have tried this maintenance niraparib with placebo, irrespective of BRCA status or HRD status. You can see that the HRD mutated with HRD with BRCA mutation, you could see a very good hazard ratio, 0.4. BRCA HRD positive, but BRCA wild type still is a very good result with hazard ratio 5, and hazard HRP homologous recombination coefficient, you could see there is still statistical significant difference. So with this prima trial, this FDO approved that we can maintain this olaparib even with BRCA status negative patient. So niraparib can be an option those who don't have any mutational status. So as you know that the ICON 7 and GOG218, these are the very promising 2 studies that showed some progression-free survival benefit with primary bevacizumab maintenance. So if the patient is on bevacizumab maintenance, so after a patient on bevacizumab maintenance, suddenly you got that the patient is BRCA status positive. So what's your take? Patient on bev, and now you got BRCA mutation status. So Dr. Ferdous Shahriar side, so are you favoring bevacizumab maintenance only, or you are in favor of giving both to get better results? Ferdous Shahriar side, sir.
Yeah, here also, if HRP is a proficient, this group, if we can do this test, then bevacizumab alone is I think is the choice, and if it is deficient, then I think I can go for both bevacizumab and olaparib. But unfortunately, these tests are not available in Bangladesh. We have to go for some other countries for this test. And without doing this test, I would not go for olaparib. I'd go for bevacizumab alone.
So your message is that if patient is on bevacizumab, if the patient is BRCA negative or HRD proficient, you will continue on bevacizumab.
Right.
If it comes with positive, so suppose this patient comes with BRCA status positive. So in this condition, do you add olaparib with bevacizumab or omit bevacizumab, or we continue with the olaparib, or combination of both?
If the patient can afford, and if there is no contraindication, then I'd go for bevacizumab and olaparib combination.
So thank you. So your take is the combination of both if the BRCA status positive. Dr. F M Kamal Uddin, sir, what's your opinion?
So you see, when we had nothing, bevacizumab was a very good weapon for us for maintenance. But after coming Parp, first of all, totally agreed that if it is BRCA negative, then we should go for bevacizumab, because when it is BRCA positive or HRD positive, then we can go for combination. But personally, if it is positive, I will go for olaparib maintenance than bevacizumab maintenance, because again, if you look at the picture of the outcome, the single olaparib is doing much better. Even if you look at the combination of olaparib and bevacizumab, the outcome is not better than the single olaparib. So I'm not going to use two costly drug where we are not getting much benefit. Rather, I keep the bevacizumab for those patients who are BRCA negative, where I cannot use Parp and I will use bevacizumab.
So thank you, Parvin, madam. What's your opinion?
Thank you. Especially in high-grade, advanced stage ovarian cancer, if BRCA mutation comes positive, then definitely I will add olaparib with bevacizumab in the maintenance, as it is now approved by FDA also, as showed in Paula 1 trial, that olaparib plus bevacizumab in maintenance, BRCA positive or HRD positive patients, progression-free survival is much better, almost double than only bevacizumab.
So you are in favor of giving both? Okay. So
please mute your microphone. Please mute your microphone.
Professor Mofazzel, sir, what's your take?
Right. As Dr. Kamal Uddin said, both the drugs are costly.
Yes.
If the patient is already on bevacizumab and the BRCA1 comes positive, I will try in some cases those who can afford both the drugs, because PFS, definitely there is combination, there is PFS benefit. But if they cannot continue both, I will definitely switch over to olaparib, because that is better one.
So thank you, sir. So this is the first time we have got two opinions among our panel of experts. So one group are in favor of keeping bevacizumab and keep the olaparib as a resort, and one group they try to keep the both at the very onset. So let's see what the studies are saying. That the Paolo 1, you could see that the high-grade serous ovarian cancer after first-line chemotherapy, they did not enrolled upon the basis of BRCA mutation status. They have enrolled all the patients, and they give one arm olaparib versus bevacizumab. And you can see again with HRD and BRCA status plays a major role. Very good result. HRD positive without BRCA mutation, very good result. And those who don't have this HRD status, it is not very significant outcome. So you can see here that the olaparib plus bevacizumab, the median progression-free survival is 37.2 months, whereas the bevacizumab arm is 17 months for HRD group, HRD of BRCA mutation group. A 20 months progression-free survival giving these two drugs at the same time. On the other hand, those who are BRCA non-mutated, HRD positive, you could see still there is around 12 months over progression-free survival benefit. So that is the interpersonal decision. I agreed both the opinion. Those who can keep on bevacizumab as maintenance and keep this olaparib as a resort, agreed. And I am very much agreed with Professor P.A. Madam and Mofazzel sir. So you could see that FDA approved in 2020 that those who are BRCA mutation or HRD positive, you could give olaparib in combination with bevacizumab. So this is the guidelines in 2021. Patient with advanced serous ovarian cancer, the first decision whether we go for neoadjuvant chemotherapy or surgery, and the second decision whether we go for bevacizumab as maintenance or not. So if the patient comes with HRD positive or BRCA mutation positive, we should consider olaparib if it is positive. If it comes with BRCA status negative, we should think about another olaparib, that is the niraparib or nuluparib. And if the patient is bevacizumab, if it is positive BRCA mutation, we can add this olaparib along with the bevacizumab. So that's all from 2021 regarding the first line management of ovarian cancer. Now come to our second case. That is the recurrent case. So this is the 63 years old woman. 2 years back, she was treated accordingly, but unfortunately, after 2 years, her C125 is started to rise, and CT scan shows that there is a recurrence of disease. So, Professor Shahana Pervin, what's your opinion in this patient? Are you in favor of going surgery?
Yes.
Professor Shahana Pervin.
Yes, yes. Grade 3
So in
can.
recurrence case, after 2 years, high CA 125, CT scan shows this is recurrence. Are you in favor of surgery or not?
If this patient, if the patient, she received the platinum carboplatin plus paclitaxel, and I will evaluate the patients. If there the performance status is good, there is minimum ascites, there is no gross residual disease, and there is no disseminated disease. In that cases, and there is in that cases only in isolated metastasis, in that cases I will go for the surgery, because in 2020 the ASCO, they have there was a session that's in China. They found that the 357 patients, all the patients who received the chemotherapy, they did a secondary cytoreductive surgery in all the patients. In that cases, they showed that those patients who have for whom the complete cytoreduction was done, then their recurrence-free survival and progression-free survival were better than that of the only chemotherapy arm. So if I am sure that I can do the complete cytoreduction, that is less than 1 centimeter disease can be residual disease, and there is no other distant metastasis and platinum sensitive disease, and also laparoscopically I will evaluate the patient, and also the CT MRI. In that cases, I will go for the secondary cytoreductive surgery.
So thank you, Professor Shahana Pervin ma'am. So for giving this very important insight. So if the patient is recurrent, definitely we should not forget about the role of surgeons, because there is a very good role of surgeon if it is possible to maximum debulking surgery. But unfortunately, our patient was not an ideal candidate for surgery. So as the patients recurred after 2 years, so we consider it as a very platinum sensitive. We offered her platinum combination with the same regime, paclitaxel and paclitaxel carbo. Unfortunately, the patient achieved a complete response or near complete response. So in this context, what you should do, Professor Dr. Ferdous Shahriar side, sir. Ferdous, right?
Sumon.
Yes.
Yes, again, this case, after getting complete response or, almost complete response with platinum combination, this patient should be on maintenance. I hope that this patient is BRCA done in this patient or not.
If it is not, then
Okay,
what?
then
And if she's yes, then what?
Make it done. If it's not done, and if it's done, then the status, and if possible, if BRCA supports it, then go for olaparib.
So this is our second topics of discussion. In recurrent platinum sensitive high-grade ovarian cancer, is there enough evidence for Parp inhibitor or not? So let's see. So there are two options, that we do have bevacizumab and we have Parp. So in last years, that the Ocean's trial and GOG212 trial, you could see that in Ocean trial, there is a significant progression-free survival, but unfortunately, there was no overall survival benefit. GOG213, there is progression-free survival as well as there is the overall survival, but the survival benefit is only 5 months. So this bevacizumab maintenance, in particular recurrent ovarian malignancy, is not a very good option for the oncologist. Now let's see what the recent trial are saying. And there is SOLO trial, SOLO 2, they have tried olaparib versus placebo after giving platinum combination chemotherapy, and they got a good result. So my question to Professor Parvin Akhter madam, Parvin Akhter Banu madam. So based on this SOLO trial, so are you in favor? Are you in favor of giving olaparib after patient achieving complete or partial response, even in recurrent setting, madam?
Yeah, thank you. If BRCA mutation done and it is positive and or HRD done, then definitely I will be in favor of giving olaparib maintenance for this patient.
So even in recurrent setting, if the patient has BRCA mutation, you are in favor of giving olaparib as maintenance.
Yeah.
Dr. F M Kamal Uddin, sir.
Yeah, Sumon, SOLO 2 is giving us adequate solid evidence in favor of giving maintenance. That if it is a relapse case, then we should go for maintenance with olaparib, because it is giving you see the curve is separated from the beginning, so
Yeah.
they are all are benefited. So we are getting a huge benefit compared to placebo.
So just to add, Dr. F M Kamal Uddin, sir, the last year, the 5 years overall survival, you could see that 5 years overall, median overall survival 51.7 versus 38.8. So there is a very commanding difference if you compare with the bevacizumab. So in this context, are you in favor of giving olaparib if the patient has BRCA status positive?
Yes, because we are giving OS benefit, and again, so what we have Bev and Parp. So Parp is doing better in second line, so definitely we should go for it.
Thank you. Professor Mofazzel, sir, what's your opinion?
Yes, there is another study, study 19, apart from Solo 2. In study 19, the BRCA status was plus minus, not known.
Yes, that
In
was
that
phase 2
case
study,
also,
sir.
yeah, that was that. In that study, it was proven that the olaparib can give progression-free survival benefit also. So, in both the cases, whether BRCA1 is known or unknown, I think there is sense making adding this olaparib as maintenance after recurrence and going into partial or complete response.
So thank you, sir. Here we have got again a consensus opinion among our panel of experts. They all are in favor if the patient is recurrence, platinum sensitive, good response after platinum-based chemotherapy, even in recurrence, we can consider this olaparib as a maintenance therapy. So again, if the patient has no BRCA mutation status, so what's your take based on this NOVA trial? So at first, I would like to ask the question to Professor Shahriar side, sir. So if the patients don't have any BRCA status mutation, so are you in favor of giving a Parp inhibitors as maintenance recurrent case?
Yes, niraparib, if it is, it's an option, that we have already discussed, and if it is available, then we can go for niraparib. And regarding olaparib, as Professor Mofazzel Hossain just told us regarding this study 19, there is an option for using without knowing the status of BRCA. So it is rational to use olaparib even if niraparib is not available.
Let's see. Here you can see that in this NOVA trial, they include all the patients with serous high-grade histology or known to have BRCA mutation. So they did not specific only on the BRCA mutation status. And after completion of second-line chemotherapy, that is the platinum-based chemotherapy, they have randomized into one, niraparib versus placebo. And you could see that those who are BRCA mutated, you could see a very good difference as expected. But those who don't have, even they got a very progression-free survival around 6 months, and you could see the hazard ratio is 0.45 and the p-value is 0.0001. So it is very significant. So based on this information, we could conclude that Parp is the real deal now in this context. So we do have different type of drugs, the olaparib, niraparib, and all of the rucaparib. I don't know whether these two, niraparib or rucaparib, they are available or not. So we really should focus on this case, that the BRCA status, HRD mutation status, and those who are indicated, we should think for this Parp inhibitors for the indicated case. Before going to these topics, I would like to highlight some toxicities. At first, to Professor Mofazzel, sir, is the very seasoned oncologist. So among these studies, we could found that the Parp inhibitors as maintenance, we need to give around two years minimum, or those who have not complete responded, we have to give her a more duration of time. So all the studies shows that there are some hematological issues, that is the myelodysplastic syndrome and AML issues with giving Parp inhibitors long time. So if we give the very first line, so what your thought regarding these toxicities? So is it a area of concern? Professor Mohammad, sir.
Actually, what the Parp inhibitors side effect say, we are not very conversant with the, because we are not using this PARP inhibitor so frequently, though we are treating a lot of ovarian cancer patients. We are using mostly chemotherapy, first line, second line, even third line. First line, we know Pacli carbo, then second line also platinum based if the interval is more than 6 months, along with either the same Pacli carbo. If it does not work, then gemcitabine, carboplatin, cisplatin. Even in third line, we are using the uh, liposomal doxorubicin or topotecan. Topotecan in very infrequently, but I use one drug which most of our doctors do not use. I get excellent result with that. That is irinotecan. So as PARP inhibitors are very expensive, BRCA1-2 mutations are unknown, most of the cases we have to rely on chemotherapies, except those patients who are going to other countries like India, Singapore. Their talk is a different issue, but we have to depend mostly on chemotherapy, and we use first line, second line, and third line chemotherapy. You have written the question, can we avoid further chemotherapy after 2 more cycles in recurrent ovarian cancer? Yes, as long as the patient gets benefit out of the chemotherapy, we can. But chemotherapy-induced myelodysplastic syndrome or acute myeloid leukemia is very rare, because we are not using the uh, what are those drugs called, cyclophosphamide or ifosfamide. I mean those who are notorious for this AML and myelodysplastic syndrome. What we are using, they are very safe drugs, except that the platelet count deterioration due to gemcitabine. That is the only difficulty I face. Otherwise, we do not face this problem. So I can continue with chemotherapy up to third line. No problem with me in that situation. But we do not have much of experience about the PARP inhibitor in practical life cases. So I will not make no further comment on that.
Okay, thank you, sir. Thank you. The Professor P. Banu, madam. And so we are talking about the toxicity regarding the olaparib, and the long-term effect shows that though the number is not very high, 4 or 6 patients in the total series, some patients presented with myelodysplastic syndrome and some patients with AML. So if we start the patient with very first line from maintenance with olaparib, 2 years, 3 years, 4 years, 5 years. So as long as we give, there is a chance of getting these sorts of issues. So should we really concerned about these issues, or we should focus only on the PFS or overall survival?
Actually, our experience with the PARP inhibitor is not that much, and we have treated only few cases, and hematological toxicity is a concern, of course. And myelodysplastic syndrome, AML, this is very rare, I think, as I have gone through. But I think hematological toxicity, sometimes patient have to discontinue the treatment, or there is a delay or gap in the course of the treatment. But I have one question here. After giving chemotherapy, neoadjuvant chemotherapy, if we, in advanced cancer, ovarian cancer, if we send the patient for surgery, and after debulking surgery, if there is our own disease, residual disease, 1 or 2 centimeter or something like that, then we have to give more chemotherapy. Then it is suggested that give 2 more cycles of chemotherapy, and then that's all. But thing is that these patients very quickly come back with the recurrence. 2 more cycles of chemotherapy with the same schedule, taxane and carboplatin, is not at all enough. And immediately after surgery, we cannot give bevacizumab also. So these are the patients we face problem with. Yeah. They come back very quickly with recurrence.
So these are the real-time scenarios, real-life scenarios, madam. I think all of the oncologists over here are really facing these challenges over their particular life. But as per your case, so those who did not achieve complete response or R1 resection, after completion of chemotherapy, all the trials, they have included all these patients. I just want to add with these things. So you can consider this Parp inhibitor if BRCA status or age admission there.
Yeah.
So Dr. F M Kamal Uddin sir, we are talking about the toxicity related issues.
You look at the Parp toxicity, AE. Yes, this scary word of AML and myelodysplastic syndrome are there. But look at the figure. It is less than 2%, sometimes even 1%. In one study, it was only one patient. So yes, it is there, but it is not that much worryful, number one. If you look at the other AE, most is hematological. But the up to grade 3, 4 is very minimum. There is no grade 5 toxicity. So apparently we can say it's a quite safe drug, even we go for a long time. So I am, if the financial issue is not there, I am more concerned about financial toxicity, not about the drug toxicity, because the number of less than 1% or less than 2% of acute AML or myelodysplastic syndrome is not a big issue there. I think the more is the financial toxicity. But I think there is another more important thing, Sumon. We need to decide when we use it. Because you see, in Solo 2, we have taken the patient who has not taken Parp before. So if we use it as a maintenance and then if recurs, I cannot use olaparib again. So the question is, we need to decide, shall we use it at the first time, seeing the huge benefit of 60% PFS, less 70% reduction of recurrence rate, or we keep it for patient to recur, then we use as a second maintenance. Or as Professor Mofazzel said, we use it again, chemotherapy, and keep it for the third time for recurrence. Because every time you see in Solo 2 and 3, the criteria is you will not recruit a patient who has received olaparib before. So using one-time olaparib, we are losing the chance of using it later. So I think this is a area that we should really think, because it's
right. Very right, Dr. F M Kamal Uddin sir. But for getting this answer, we have to wait the mature overall survival data of Solo 1. That will really conclude all these issues. So we are running short of time. So as Mofazzel sir giving her inputs regarding these issues, I want to hear from Professor Banu madam. So if the patient is heavily pretreated, platinum, though he is platinum sensitive, so can we avoid this chemotherapy? So I am going to show this study, Solo 3. They have tried patient getting 2 or more cycles chemotherapy. After that, no chemotherapy, olaparib versus non-platinum chemotherapy. And they got a very good result. You could see that olaparib, 72% response versus chemotherapy. There is a very good difference. You could see those who are heavily pretreated with more than 3 cycles prior chemotherapy, 59 versus 39. So Parp inhibitors can be an answer for this group of patients, those who are very heavily pretreated, but the prerequisite is BRCA mutations. So what's your opinion, madam?
Yeah, it's a very good trial to show us that heavily pretreated patients can be given olaparib, and also showing good progression of ORR, that is objective response rate. That is a very good option, I think. But same thing that patients should have done that BRCA test, that is germ cell BRCA test before giving olaparib. I think in this trial, I think it is and prerequisite to do a BRCA test, then enroll the patient.
Right.
Now we can avoid chemotherapy. That is a very good option. Yeah.
So thank you. Due to the time constraint, I am not going to discuss with our other panel of experts regarding issues. So let me summarize today's whole discussions. That in 2021, the ESCO guidelines, at the first line, we can consider this Parp inhibitor. We can consider niraparib to all patients irrespective of BRCA mutation status as maintenance. But if we need to give olaparib, we need to check the BRCA mutation status. And the second line maintenance, we need to check whether the patient is responding to platinum sensitive or not. If it is platinum sensitive, we could consider these Parp inhibitors. Again, the same rule, If it is olaparib, you need to check about the BRCA status. And if you want to give niraparib, you can avoid this status. And treatment for further recurrence, if the BRCA mutation is there, you could avoid chemotherapy. You can start very first line with the Parp inhibitors. That's all. But in the lower box, they have given some clause that do not retreat with Parp inhibitor. So if there is a progression with Parp inhibitor, so you don't retreat with Parp. In recurrent setting, avoid combination Parp with chemotherapy. So you don't push your patients beyond the limits. So giving more does not result in more. So that's all from today's discussion. I would like to give a very special thanks to all our iconic figures of oncology for giving their time, giving their very inputs. Now I would like to take message from our chairperson, Professor M. Heiser. Then I would ask our contributor, that is the scientific partner. And again, I would ask Professor M. Heiser to give his comments as a chairperson. So Professor M. Heiser, what's your take-home message for our participants regarding the Parp inhibitors? Professor M. Heiser.
Sumon, there was a question about the cost of olaparib of 1 month's treatment. You should have highlighted that point because somebody asked the question.
Sir, better to get this answer from this company point of view. Sir.
Okay, let them explain, right?
Yes, sir. Yes, I keep this question for the company people. So, Professor M. Heiser.
Okay, thank you, Dr. Sumon. It was a wonderful session today. Yes, really, I admire your presentation and also the discussion of our learned panel members. Take home message, you have already said that Parp inhibitors, that is only this olaparib and niraparib. Never is not available in this country, but olaparib is available. But again, then our BRCA test is not also available. So we shall have to organize these things, BRCA test, as we can. And overall, I have nothing to add. We have all discussed, we have all heard, we have all seen the slides. It was wonderful. I'm happy that you are continuing this thing. On the eve of this World Ovarian Cancer Day, there we have observed. Thank you all very much.
So thank you, sir. Thank you for your inputs. Again, in the later part, we will get a closing remarks from you. So now, as you know, today's scientific partner was Everest. So now I'd like to request Shanta Paul, a representative for Everest.
Thank you, sir.
And as the question was raised regarding the price, I think you should say some words regarding the price and how you could cut down a bit regarding this price issues. Shanta Paul.
Thank you, sir. Assalamu alaikum. Very good afternoon. Honorable Chairperson, distinguished panel of experts, moderator, and participated all respected oncologists and gyne-oncologists. My heartiest thanks to the moderator, Dr. Mostafa Aziz Sumon sir, to give us the opportunity to be a co-sponsor of this scientific seminar. First of all, I must mention our deep sense of appreciation to Oncology Club for organizing this scientific webinar on expanding role of Parp inhibitors in ovarian cancer. This was very nice discussion, and on behalf of Everest Pharmaceuticals, I would like to extend a very hearty vote of thanks to the chairperson, Professor Dr. M.A. Heiser, for gracing today's webinar with his valuable speech. Then I would like to express my sincere thanks to all renowned panel of experts, Professor Dr. Mohammad Mofazzel Hossain sir, Dr. Parvin Banu madam, Dr. F M Kamal Uddin sir, Professor Dr. Shahana Parvin madam, Dr. Ferdous Shahriar sir, and last of all, moderator Dr. Mostafa Aziz Sumon for their nice, for sharing their nice knowledge with practical experience, their personal findings and opinions. Dear doctor, you know that Everest Pharmaceuticals started its glorious journey in 2017 through groundbreaking production of the global first generic of olaparib, that is our Olanib, And after that, receiving very encouraging response from global and local oncologists, we have introduced Niraparib and other 12 different kind of oncology products to serve the global cancer patients as well as Bangladeshi patients. Here, I would like to inform you that our Olaparib monthly cost will be like 80,000 taka. But if you want more discount for your poor patient, we will try our best to less this, then about 70 to 75,000 also. And many patients are now taking our Olanib at this price. So, sir, thank you. And last of all, I would like to express my wholehearted gratitude to all doctors for serving cancer patients with Everest brands. May Almighty bless all of you and your family with sound health in this pandemic situation. Thank you all, sir. Thank you.
Thank you, Dr. Shanta. We are at the right time at the 3 p.m. Now, I would like to request our chairperson, Professor Hossain, President of Oncology Club, to say a few words and conclude this session. Professor Hossain.
Thank you, Sumon, once again. My job is to say thanks and nothing more. I've learned many things, I've heard many things, and I think our discussions were very good. And my thanks to Everest also. I'm not so much they have helped us organizing this webinar. One thing I would like to say that those who cannot afford Parp, can we go first? Taken as Mofazzel has said. His experience is has got a very good result. I think those who cannot afford, they can go for it. Those who can afford, so certainly we could go for this year. Santa said that they are also taking Niraparib. Niraparib is available, I don't know what is the price. That we can use for PRC positive and negative for both the cases. You can use it blindly. So those we don't have any facilities for testing PRC 1, 2, we can use Niraparib. This is what we can say, and I would congratulate all of you for joining us and for the club. Thanks to all of you.
Thank you. So without any delay, so with your permission, I would like to close this session. So thank you all the panel of experts. Thank you Evercare for being the scientific partner. So thank you all. I think we should focus this sort of program frequently to bring some new challenges in oncology field. So till then, thank you. And with this opportunity, I would like to recall you all that tomorrow we have another regular CME, that is Sunday 3 p.m. Tomorrow we'll discuss on colorectal surgery, surgical point of view. So see you tomorrow in 3 p.m. So till then, goodbye all and stay safe. Thank you.